line is somebody who has no opioid exposure with a painful condition. They're going to have some fluctuations over time. If, for instance, I've got knee arthritis, as I'm standing here, it's going to start to build irritants, and it's going to start to ache a little bit more. But the moment I sit down, that aching can subside, and it goes back to normal. So that's how I have that fluctuation of up and down. And when you average that out over time, you can get kind of like an average perception of pain. Now, somebody who is taking opioids would be the red line once we get it back up. And they have this similar experience, these ups and downs to their pain. The difference being that the exposure of opioids reduces the pain when they take it, but it also increases your sensitivity of pain so that the moment the pain medicine is gone, you're rebounding and you have a higher perception of that pain. Your threshold is now lower than it was.
Are there other phrases that have been used to describe that rebound pain?
Yeah, so there's a term called hyperalgesia. Algesia means pain. Hyper meaning, of course, increased pain. So some would describe this as this peak of pain as a hyperalgesic response, or what I explain to patients is that you're just more sensitive to pain. So over time, when we look at this, your tolerance to the medication is increasing. So the reduction in pain that you get from an opioid becomes less and less and less over time. But your sensitivity doesn't seem to change a whole lot. You continue to be sensitive, if not become even more sensitive. So at the starting point, you could say that the person who's taking opioids might get a little bit of benefit. They might have actually even a lower than normal pain perception. But as time carries on, that they lose that benefit. And over time, they actually have a higher sensitivity of pain. Their pain is actually more intense than it would have been had we never started opioids to begin with.
What type of time frame are we talking about here?
That's not well known, but we know that even a single injection of fentanyl will increase people's both pain sensitivity and also the region of pain that's affected. So if, for instance, my pain is coming from here, the other nerves that I talked about coalescing in the spinal cord, other nerves are going to be lumped into that area. And it even goes further. It's not just the other nerves that in that area, it's other sensations in that area. So for instance, the nerve that signals sharp touch or sharp pain is going to be mixed up with the nerves that just control movement or control the sensation of touch. And if you look at people who have had long-term opioid exposure, you touch their skin and they're sensitive. And it's because that lumping effect that takes place in the spinal cord.
So Dr. Mazloomdoost, there are a few things on this demonstrative that I'd like to ask you some questions about.
Yes, sir.
First, let's clarify, the red lines are representing someone who is on opioids.
Correct.
And the blue lines represent a patient who is not on opioids.
Yes, sir.
Okay, thank you. Now we also see some blue arrows that say prescription opioids or RX opioids in them. Can you please explain why those are there?
Yeah, so a lot of times patients are told if you have breakthrough pain, you need to take your pain medicine. But how do we differentiate in this patient these natural undulations that happen with any kind of pain condition versus the rebound pain that they're feeling because of the opioid exposure? You really can't differentiate the two. Every time they hit that peak, they're getting the signal that, oh, it's my pain that's worse. So if I'm taking my pain medicine as needed, every time I hit this peak, I need to take it, rather than waiting for this peak to naturally normalize, which it would. Even if they're taking opioids, if they waited long enough, that curve would normalize and they would go back to close to normal. But if every time they're hitting this peak, they're getting the signal that they need to take more pain medicine, they're progressively developing not just the physical dependency, but the psychological dependency that it's the medication that's giving them this relief. That's the reason that they become so resistant to the idea that the medicine is making things worse, because they're not seeing this average trend go up. they're only seeing these peaks and troughs. And they're seeing the association that every time I take a pill, I'm getting some relief. So they become attuned to the fact that it's the medication that's their savior, not the biological system. They don't understand everything that's going on. They can't see that long-term scope. They only see the momentary scope.
Thank you. Were you about to ask a question? I'm
No.
sorry, I didn't mean to
No.
interrupt.
You're good.
So the red line, the red dotted line, does that represent the average pain experienced by a patient on opioids?
Correct. Yes.
Thank you, doctor.
If we want to go to the next.
Well, let's hold off on that, and we might come back to that later. Thanks, Mike. Okay, Dr. Mazloomdoost, you've now explained, using these visual aids in detail, some complex issues around pain, right? Sorry, can you answer?
Yes, sir.
Thank you. And, however, we do understand quite a bit about pain. Isn't that right?
Yes, sir.
Okay, now, have you treated patients from Oklahoma?
I have. Yes, sir.
Have you treated patients from Texas?
Yes, sir.
Have you treated patients from Maryland, where you went to medical school?
Yes, sir.
Have you treated patients from other states?
Yes, sir. Tennessee, Ohio, Kentucky, of course, West Virginia.
And these concepts that you just described, concepts related to pain, the concepts related to opioids, do these apply generally to all of the patients that you've treated?
We're all made of the same fabric. Yes, sir. They all fit.
And do opioids do the same things in all of those patients?
They're absolutely universal. We all have that system in our brain and the same receptors.